leading causes of maternal death still are hemorrhage, followed by sepsis. And this sepsis contributes to around 12% of maternal mortalities. So maternal sepsis, we know, is a significant cause. There are certain risk factors, like if a woman is nulliparous or cesarean deliveries, ART technology, which is so rapidly catching up, and multiple gestations, they definitely play a very contributory role in maternal sepsis. More than 50% of the women who die from sepsis have chronic comorbid conditions. For example, they can either have hypertension, diabetes, renal disease, liver disease, or a congestive heart failure, which really contribute to it. Now, we all work in very busy settings. And if we have a case scenario like a woman who is multiparous who comes to us with day 3 post-cesarean with shock with anemia, with cesarean section done outside, where her blood pressure is low, already on inotropes, high temperature, and abdomen is tender with foul-smelling lochia. Or we also have women who have post-abortal sepsis. They are in shock with, again, poor general condition of E1, V5, and M2, and hypotension. So I'm sure these are very, very common scenarios which we see very often. Now, the question which comes to our mind is that these women have sepsis or infection. And what is the difference between these two words? Are these words, can we use them interchangeably, or do they have different meanings? So we're going to be talking about that before we go on to the sepsis bundle. So there are 3 words: infection, sepsis, and septic shock, and all 3 of them are in a spectrum. Sepsis is defined as life-threatening organ dysfunction, which is caused by a dysregulated host response to infection. So that means infection with something constitutes as sepsis, and septic shock is sepsis when it is associated with hypotension, despite fluid resuscitation, which leads to cell function and cell death. So that means sepsis is not just infection, sepsis is infection with organ dysfunction. And when we say bundle, we mean that bundle is a structured way of improving the processes of care and patient outcomes. So that means there are multiple activities for 3 to 5, which not necessarily should be done in a sequential manner, but they should be done together and reliably so as to improve the patient outcomes. Okay, so we are going to be talking about sepsis bundle. Now, when we say organ dysfunction, so that's a very vague term, but if you look at the systems of the body, we know what we are talking about. For example, if a woman has an altered mental status, like she has delirium along with infection, so she has sepsis. If she has sepsis along with myocardial dysfunction or hypertension, she again has sepsis. If she has ARDS, if she has paralytic ileus, if she has hepatic failure or elevated transaminases, if she has oliguria or acute kidney injury, if she has thrombocytopenia or DIC, or if she has adrenal dysfunction, any of them, it constitutes as organ dysfunction, and that is what qualifies as sepsis. But we must also remember at the same time that fever sometimes in such situations can be absent. The cultures may be negative and the source is not always seen. Sepsis always remains a clinical condition, even if you think that none of the lab investigations are pointing towards it, but clinically you think that she has infection along with organ dysfunction, we can label the woman as having sepsis. Now, in the maternal physiology, we know that there are a lot of changes which happen during pregnancy, and because of that, a lot of problems get masked, and a lot of immunity changes keep happening during pregnancy, which makes us more confusing. For example, we know that pregnancy is a state of modified immune function. We also know that in pregnancy itself, there is tachycardia, there is vasodilatation, there is an increased respiratory rate. All these things can actually, in a non-pregnant person, point towards some kind of a problem happening. But in pregnancy, that is completely normal. And similarly, if you look at the diagnostic investigations, even creatinine and mean arterial pressure, they have different values in pregnancy. So that means sepsis in non-pregnant women and sepsis in pregnant women, they are different things. So we need to understand that completely. Now, when we say sepsis, a woman has sepsis because she has infection with organ dysfunction, how do we measure it? So to measure it, we have 2 scores, which are called as SOFA score and quick SOFA score, also abbreviated as Q-SOFA. So SOFA score, we all know it is used in ICU settings. We don't need to again memorize it, but just we need to remember that there are certain parameters which are categorized as 1, 2, 3, 4. And these parameters are respiration, coagulation, liver functions, cardiovascular, CNS, and renal. Now, all of them are given scores. So when a person comes, then the scores are calculated, and depending on that, the management is done. Now, we know that this looks a little confusing and overwhelming. So to counter that, we have a bedside assessment score, which is called as quick SOFA score or Q-SOFA score. Here we take only 3 criteria. We look at the systolic blood pressure, we look at the respiratory rate, and we look at the mental status. Now, initially, the systolic blood pressure was taken as less than or equal to 100, but has now been revised to less than 90 millimeter of mercury. The respiratory rate was initially 22, more than 22, but now it is more than 25. So if we have these 3 clinical criteria, 2 or more of these criteria are present, then we know that organ dysfunction is present, and we should immediately start looking for what is happening inside her. So if either her blood pressure is low, less than 90, respiratory rate is more than 25, or she is in a little delirial state, then you know that she's having sepsis. But if a patient has gone into an ICU, then remember that then quick SOFA is not the bedside assessment tool. Then you need to have a full SOFA scoring. And if SOFA score increases by 2 or more points, then we know that a woman is going into sepsis. Now, sepsis can be antepartum or postpartum. It can be an obstetric condition or a non-obstetric condition. In antepartum, we know that there is a first trimester complication. It can be a septic abortion. Second and third trimester, the leaking is happening. Then we say it is chorionitis. In postpartum, we know that the placental bed has very high predisposition to infection, so it can lead to endometritis, or sometimes surgical site infections are also. And if there is associated organ dysfunction, it can be termed as sepsis. Non-obstetric can be like any other non-pregnant population, like UTI, pneumonia, appendicitis. Even in the postpartum period, it could be UTI, pneumonia, or any GI infections. Now, this is about the basic understanding of sepsis. Now we come to what should we do when there is a woman with sepsis. Now, there are 4 basic principles. First, we need to see what is happening with her vasodilatation. Because of vasodilatation, what is happening to her hemodynamic parameters. So assess and correct the perfusion. Look for the organ dysfunction. Begin appropriate antibiotics and take the cultures. But don't think that, oh, I can't send the cultures right now, then how can I start antibiotics? Start antibiotics for the patient, and cultures, try to obtain them as early as possible. Now, when we say bundle, as I said, we're talking about 3-4 activities which have to be done together. And this is what is sepsis resuscitation bundle. Now, sepsis resuscitation bundle, it says that do certain things within 6 hours, do certain things within 24 hours. So within 6 hours, these are the few things which says that you measure serum lactate. Now, serum lactate sometimes is not available in our usual laboratories, but if we read the ABG investigations, we will realize that lactates are always mentioned in ABG. So if you think that you can get an ABG done, or the patient has some kind of an reason, hypotension or respiratory distress, immediately get an ABG. It will give you a much added information. Take the blood cultures. Try to give antibiotics as soon as possible. In the event of hypertension, when the blood pressure is less than 90 or lactates are more than 4, you have to first perfuse her, give her crystalloids bolus, and that crystalloid bolus is 20 ml per kg. So that means on an average, if a woman is 60 kgs, which we take an average Indian woman, you have to give at least 1 to 1.2 liters of crystalloids. And with crystalloids, we mean normal saline or ringer lactate. Never give 5% dextrose. But despite fluid resuscitation, if the blood pressure is not rising, and when with blood pressure, we mean the mean arterial pressure. If the mean arterial pressure is more than 65, then you don't need to give vasopressors. Otherwise, you should start vasopressors. And if there's persistent hypertension and lactates are high, then you can also look at central venous pressures or central venous oxygen saturations to know if the woman is stabilizing. So this is about first 6 hours. Now, first 24 hours, there are other things, but these things have to be individualized, because you can have steroids like hydrocortisones, which can be given in women with sepsis, but it has to be given judiciously. because we have seen that steroids can still benefit women of sepsis because there is some kind of an adrenal suppression which is happening in these women, and these steroids help to counter that. Then droticorgan alpha, which is nothing but activated protein C. This case is also given, but again in ICU settings with physician's consultation. Try to maintain the blood sugars and also maintain the plateau pressures in mechanically ventilated patients. So simplified version of a sepsis bundle is also called a sepsis 6, which I think is much more easy to understand. Here, what is mentioned is that you should give high flow oxygen, take blood cultures. Here, it's specified that give both aerobic as well as anaerobic cultures. Try to take 2 sets of blood cultures, never 1. And these 2 sets of blood cultures should be one from a vascular site and another one percutaneously if possible. For example, if there is an abscess, if there is a collection, then try to aspirate that and send that for cultures. Administer broad spectrum antibiotics. I will come to that, which antibiotics to give. Measure serum lactate if possible. It gives us a very, very valuable information because there is no other way to understand tissue perfusions if you don't have lactate levels. And then fluids, as I said, 20 to 30 ml per kg. On an average, it is between 1 to 1.5 liters. And of course, if the lactate levels come, you know that if the lactate is more than 4, the woman is having tissue hypoperfusion, and give her fluids first. Catheterize the women and measure the urine output on an hourly basis. Now, along with the sepsis 6, also begin the search for focus of infection. From where is this infection coming? Is it a surgical site infection? Is it a pelvic abscess? Is it a thrombophlebitis or any other site which we know we can think of in a antepartum or a postpartum women? If necessary, do the imaging to identify what is happening. An appropriate intervention should be done to remove the source of infection. And this should be done as soon as you stabilize the patient. And when we were residents and much younger, the standard teaching used to be that stabilize the women for at least 24 hours, stabilize the women for at least 48 hours, let antibiotics go, then only think of touching her or taking her for a surgery. But now the sepsis 6 or the sepsis resuscitation bundles, it stresses on the need for surgically removing the source of infection as soon as the woman is stabilized. And that is important to note. Now, I've already told you about the fluid therapy, where you have to give around 1 to 2 liters of crystalloids, and crystalloids can be either ringers or normal saline or isolite M. Albumin may also be included, and however, synthetic colloidal solutions, which sometimes we think help in better maintaining the colloidal oncotic pressure, but they are not recommended to increase the tissue perfusions. Now, this is a very simple thing, that how to know whether the fluid which you have given is enough. Maybe the woman is so severely dehydrated, maybe there is so much of tissue hypoperfusion, then we can do a passive leg raising. Just raise her legs by 30 to 45 degrees. Obviously, this is not going to work in the 3rd trimester because there the venous compression is happening. But otherwise, you raise her legs by 30 to 45 degrees, and that transfuses blood by around 300 cc. And if there is a change in her cardiac output, you know that the fluid resuscitation is going to work, or it is working. Another thing which we now very often encourage our residents to do is just put a probe on the IVC. If the inferior vena, which is very easy to spot and identify on an ultrasound. So if the IVC diameter is less than 1.5 centimeter, and there is a significant variation in caliber, that means because of the pulsation, because of the breathing, there are pulsations seen, then you know that this woman needs more fluid. However, if the IVC diameter is more than 2 to 2.5 centimeter and it appears tensed, that means there is very minimal variation. So that means this woman is already fluid overloaded, and do not give any more fluid because you will end up pushing her into pulmonary edema. But 1 liter in patients who have sepsis can be safely given. It's only after that you can do this point of care ultrasound to understand if you have given enough fluid. Maybe if you give more, the women will improve, or you've already given enough and you need to stop. So sample collection, as I said, is very important. Try to do it as soon as possible, but still do not delay antimicrobials just because you have not been able to take cultures. Cultures should also be taken from high vaginal swab, should take midstream urine, wound swabs, throat swabs, etc., depending upon where you think the source of infection is. Serum lactate levels, as I said, it's a surrogate marker. It's not a direct marker, but we know that if lactates are high, the tissues are very hypoxic. And if the lactate level is more than 2, start intervening. However, if it is more than 4 and not improving because of fluid resuscitation, then you know you have to start vasopressors. And vasopressor of choice in these patients is always noradrenaline. Now, choice of antibiotics. Now, depending upon the condition of the patient, suppose if the patient is not so ill, she's having organ dysfunction, she's having infection, then you can start her on coamoxiclav or cefuroxime, which is a second generation cephalosporin, or cefotaxime and metronidazole, depending upon whatever the availability is this in the government settings or whatever the injections are available. If a patient is allergic to penicillin, then we need to give macrolide like clarithromycin, or in these women, we can also give clindamycin and gentamicin. However, if the patients are critically ill, then these antibiotics are not enough. You need to step up further. Give her either piperacillin or tazobactam, meropenem, ciprofloxacin and gentamicin, and metronidazole can also be added to cover the anaerobes. So this is a very important thing to understand. Don't start antibiotics, without thinking about them. Be mindful when you are actually starting antibiotics depending upon the condition of the patient. Now, obviously, after we have done her examination and we have done her stabilization, as I said, we have to start looking for the focus. What has led to this condition? And there, wherever on clinical examination we have any kind of a suspicion, then we need to start doing the imaging. Because as I said, we have to remove the focus of infection as early as possible. So the imaging can range from ultrasound of the affected organ, or can CT scan or MRI, abdomen or pelvis, as the need may be. So again, as I would like to repeat here, that sepsis 6 has to be followed, where you administer high flow oxygen, give antibiotics, take cultures, measure lactates, give fluids, and also measure the urine output. And within 6 hours, you also administer the vasopressors if the woman is not responding to your fluid resuscitation, and continue measuring serum lactate if the initial lactate was elevated. Otherwise, as I said, you will not know how the tissue perfusion is improving. And if the tissue perfusion is not improving, how much ever we may try, it will lead to organ damage and organ death, and then it will become very difficult to take her out of this sepsis situation. Now, bicarbonates, everybody thinks because there is tissue hypoxia, there is acidosis, bicarb laga do. But bicarbonate therapy is contraindicated and we should never do it because we will push the patient to renal shutdown. So vasopressors only if the woman is not responding to fluid resuscitation. If the blood pressure is low, don't be in a hurry to start vasopressors. Give her fluids first, 1.2, 1.5 liter of crystalloids. Also look at the various things which we have just discussed to decide whether you need to give further fluid, or if you think that now the woman has been given enough fluid, then you start vasopressors. Norepinephrine is the drug of choice. It's a very safe vasopressor. Our target mean arterial pressure should be 65. Dopamine should be used only in certain reserved conditions where the woman has bradycardia, because with sepsis, the woman would be having tachycardia, dopamine will further increase the heart rate, and the women will go into congestive heart failure. Use corticosteroids also if there is a need. So this is a chart, algorithm chart, which I would like to share. That again, the same thing, but we need to remember this so that we know what is to be done, whether maybe we're not missing anything. So it is important to remember this algorithm. Again, the same things which I have just told. Get cultures, lactates, administer antibiotics and give fluids, start vasopressors, steroids if needed, and remove the source of infection. Now, because the woman is pregnant, we should not forget that we need to do also electronic fetal monitoring, right, whenever we think the fetus is viable. Along with hydrocortisone, which you are giving for stabilizing the maternal condition, you can also give dexamethasone and betamethasone, because these steroids are needed for fetal lung maturity, and in those conditions, hydrocortisone is not going to do anything. The other supportive treatment is you can start on early enteral feeding with the help of Ryle's tube, DVT prophylaxis, and also control the blood sugars. We have come to that now, the blood products. Now remember, blood products are also, they play a very important role in women who have sepsis. If the hemoglobin is less, how much ever you give fluids or vasopressors, the tissue oxygenation is not going to improve. So we need to give a women packed RBCs. Fresh frozen plasma only in those patients who have bleeding, not just on the basis of lab values, that INR is 1.4, okay, isko FFP de dete hain. Only if a patient is bleeding, only then we should go and give fresh frozen plasma. And prophylactic platelets only if the platelets are less than 10,000 or less than 20,000 and the woman is at high risk of bleeding. For example, if she's aborting or if she's going in labor, then obviously we need to improve the platelet count to at least 50,000. Otherwise, if the woman has delivered and she's not bleeding anywhere, then the platelet count which we need to monitor is up to 10,000. Ventilation should be given if needed. Glucose controls, as I said, bicarb therapy should not be given. Prophylaxis with low molecular weight heparin or unfractionated heparin with compression stockings should be given. But if a woman is, you think that she has high chances of bleeding, then avoid the use of heparin. Stress ulcer prophylaxis like proton pump inhibitor and oral or enteral feeding. Now, is the delivery indicated in all the women who have sepsis? The answer is no, except if the woman has choriamnitis. Because choriamnitis, you need to do a delivery because that is the source of infection. And decision to deliver the fetus should be individualized, because we also need to remember that a woman who is pregnant, in them the resuscitation efforts are better if you evacuate the uterus. But again, see, individualize the patient. If you think that you can salvage the baby by waiting for a couple of hours, and try to wait that so that you can have both mother and the baby. But if you think that the mother's condition is severe enough, then obviously we need to act immediately. Delivery should be reserved for obstetric indication, and there is no evidence as such that just because for example, you can have a woman who comes at 34 weeks with pneumonia leading to ARDS. There is no evidence to say that if you deliver her, it will improve the outcome. But if you think that she needs resuscitation, then maybe you will be better off if you deliver her, because resuscitation would be better. And the surgical procedures which we need to do as soon as possible, as soon as the mother is stabilized, is if there are retained products of conception, they have to be evacuated. If there is a surgical site infection, debridement has to be done. If there is an abscess, drain it as soon as possible. If there is pyelonephritis, again, you can do a percutaneous nephrostomy with the help of surgeon friends. Choriamnitis, deliver the baby. If there is myometrial necrosis and gangrene, uterine gangrene, then we need to do hysterectomy. If despite all this, the patient is not improving or she needs airway protection, there is pulmonary edema, ARDS, persistent hypertension despite all your efforts, or she's going into renal shutdown, multi-organ failure, or delirium, it's better to transfer her to a best critical care so that she can be taken care of. So this is again the last slide, just to reiterate whatever the things we have discussed just now. This is again an illustrative chart where the same 5-6 things which I have just spoken in the bundle, we need to remember all of them so well so that we don't forget any stick of this bundle. So that is why I have put this slide again. If again, as I said, in the bundle, all the things have to be done. It is not necessary to follow the sequence, but it is necessary that we do each one of them so as to improve the patient outcome. So to summarize, give hemodynamic supportive therapy, give good antibiotics, remove the source of infection. If there is choriamnitis, deliver her. Give corticosteroids for fetal lung maturity, and don't be worried because she's having sepsis, the infection will flare up. Immediate delivery solely due to sepsis should not be unknown. Thank you so much. And these are my references where we were talking about the latest guidelines. So the slides have been made through the Society of Maternal Fetal Medicine Consult Series 2019. And then we also had maternal sepsis and septic shock recently. And the rest of the recent articles, which are very wonderful and they're easily available on the internet. Thank you so much.
Thank you, Dr. Smriti, for a very comprehensive talk and with so many good clinical tips. It's my pleasure to listen to you. It was really wonderful. And I would like to add on here, emphasize rather, a quick SOFA score is, I think, very useful because we don't need to wait for the lab investigation report. So we can work on it. And very rightly you said, in our PG days, we used to wait for the treating with the septic focus. But now the recent guidelines, we have to deal it as fast as possible. Wonderful talk. Thank you so much. Very elaborate and with very beautiful clinical tips. Thank you.
Thank you, ma'am.
I just want to say it was an excellent talk, and we can say that real academic feast arranged by Dr. Shada Jain. It was needed. This was a need of our controlling. So you have not left any point, Smriti. So I don't think we should repeat it. But as Doc Sab said, that international guidelines has to be followed. So we all know sepsis, oof, it was an havoc in our time. But we all know now the care has improved a lot. And improving the quality and uniformity of the management of the sepsis, we have to follow the international guidelines, and these are being fixed time to time. There is Sepsis 6 bundle, which was proposed by UK Sepsis Trust. I think so. I may be right.
You're right, ma'am. Yes, completely right, ma'am.
Because I was very much impressed by that 6 bundle of sepsis treatment, and I know it is being followed, and especially to keep it uniformly, globally uniform, we have to follow that. So, in the end, I just want to say management should be accordance of the international guidance, as Dr. said. And as we know, we are living in an era of evidence-based medicine. So it has to be followed. Thank you, Smriti. It was wonderful talk.
Thank you, ma'am.
And your comment was wonderful, huh?
Thank you so much.
Thank you, Smriti. It was a very, very like highly, very concise and the crisp thing. One or two things just I wish to say that the sepsis care bundle, that they are revising their guidelines every 4 years, and the 2021 has come. And there are 2 or 3 things which they have added. One is that they are favoring the isotonic crystalloid, not normal saline. So this is one thing. And the second thing, what they have added, that steroid was initially actually in 2016, they say that it is only when it is not responding. But now they have like that has been added, that the steroid can be added in the initial phase because it has been proven a good outcome. And thirdly, very, very important thing which has been added in 2021 is that the care for the post-sepsis mental health. So about the mental health of the patient who have undergone the sepsis survivor. And this maternal fetal medicine, what you have really emphasized, that the delivery is not a sole indication only for the sepsis. So these are the few 2021, that is a way progress, that the only isotonic saline and not normal lactic have been added to. Is important thing is what Smriti have said, that it has to be implemented in our like labor rooms and in our hospital setting, because that implementation, and we have to have a audit about it, that we implement these things. So with all North India Gynae Forum UP chapter, Smriti, you are a leader and academician, that we really follow all these things. And wonderful thing that inferior vena cava, which like now this is something which we can do it, and that was a very, very good point. Dr. Manju Verma want to say something before we go on panel.
I just want to have a clarification for everybody, that if a patient comes with a hypotension, if the blood pressure is less than 80, would you like to give 2 things simultaneously, the IV fluids and the vasopressors, or would you like to wait for 6 hours and then give?
No, ma'am. So initially, ma'am, 1 to 2 liter, 1 to 1.5 to be safe. 1 to 1.5 should be given.
How many minutes? In how many minutes or hours?
In an hour to 1.5 hours, we should give it, and then assess the patient. If her blood pressure is improving, then only we don't need to start her on inotropes. Inotropes should be reserved only where the woman is not responding to fluids, because it could be just clearly a case of vasodilatation because of sepsis leading to hypertension.
So that's what I'm saying. That's what I'm saying, that this has to be emphasized, that one has to be very, very critical in starting. You just cannot wait for 6 hours for the things to come back.
Yes.
You have to be very, very critical regarding the condition of the patient. If the condition of patient is not improving, because this is an era of consumers forum. and a lot of litigations and a lot of gundagardi. That is, they start saying. But then, yes, we have to be very, very, clear and critical. Management has to be there that this is the time that we should start the inodoms.
And ma'am, we should use the technology which is available. That is, the portable ultrasounds are there everywhere in every labor room. Just put a probe on inferior vena cava.
Because this
So
I
much
would like.
difference.
I would like to disagree with you here because this is a thing which is available in the cities, and most of the deliveries they are taking place in the rural circumstances. So this is good. As an academician, and as a person, we should know about it. But this cannot be uniformly implemented everywhere. So this is a good sign that we have an ultrasound. But yes, there are still in PHCs, we don't have an ultrasound. If we have an ultrasound, we don't have an ultrasonologist. So this is really very, this is a good academic point that if we can use this. But
Maybe
for
we should
implementation,
start
the
using it in the
guideline,
medical
I think,
colleges.
Totally
Yes.
agree.
yes,
We should start using it in our medical colleges and slowly,
yes,
slowly
first, and
populate
then it
down.
can be expanded. So yes, true.
Thank you, ma'am.
Thank you.
Thank you for your inputs.
So thank you, Speaker, and thank you,
Know,
Chairpersons.
Smriti, that you are from the same place as myself from PGI Chandigarh. And I just want to tell everybody is that few things have changed. It is mean arterial pressure, it is lactate, crystalloids, no bicarbonates. Otherwise, you're going to push this particular patient.
These three things.
Thank you so much, ma'am.
Thank you, ma'am, for your wise inputs. And thank you, Chairperson, for conducting the session so very smoothly and for your inputs also. So quickly moving towards our panel discussion today on maternal sepsis, a silent killer, case-based discussion. For this, I would like to invite our moderators, Dr. Sangeeta Rai from BHU Varanasi, and we have Dr. Sikha Sachan also from Varanasi. Kindly display this CV. Bhumika, kindly display the CV. Next. Okay. Dr. Sangeeta Rai is presently professor in the Department of OBGYN, BHU. She is Secretary BOGS from 2019 to 20 and Joint Secretary of Varanasi Menopause Society. She was convener in UPCOG Urogynecology Workshop in 2019. She has conducted many workshops for reproductive and urogynecology and has more than 50 publications in international and national journals, speaker at many state and national conferences. She has written chapters in books regarding postpartum depression and HPV infection. Her areas of interest being adolescent health, infertility, and minimal access surgery. A very warm welcome to you, Dr. Sangeeta. Then we have with us Dr. Sikha Sachan. She had been a lecturer in GSVM Kanpur and MLN Medical College, Allahabad. She's Associate Professor, Department of Obs and Gynae in Banaras Hindu University. She has presented several papers in various national conferences and won the prestigious Karan Gupta Foxy Award. She's got first prize in senior quiz in UPCOG 2018 and first prize in paper in ISAR ISPAT 2019. A very warm welcome to you. We have as experts Dr. Sadhna Gupta. Ma'am, we know, is co-chair SAPOG Institute Committee and she is a great academician. And we have with us Dr. Sharda Jain, ma'am, fondly known as Teacher of Teachers and Director Life Care Center and Life Care IVF. She is founder, Secretary General of Delhi Gynecologist Forum, a body of over 2,500 members. She is founder and chairperson of North India Gynae Forum, body cover 10 states. She is ethical committee member and apex body of 14 lakhs modern medicine doctors since 2018. Business World included her in top 20 most influential women in healthcare in India. She's DMC expert since 2009. She's a passionate medical activist and has given leadership role in removing female feticide, movement of anemia, Save Uterus campaign, Save Ovary campaign, and Every Mother Counts. She has given the concept of Janani Suraksha Yojana an ASHA worker to the Government of India, and superheading movement of doctor safety, medico-legal awareness unity of the North India gynecologists. A very warm welcome to you, ma'am. As panelists, we have today a galaxy of experts, Dr. Aradhana Singh. She is Additional Professor, Department of Obs and Gynae, AIIMS Gorakhpur, Fellow of Indian College of Obs and Gynae, and Fox's CS Dawn Award for paper presentation. She's a very active member in our society and has special interest being gynae endocrinology. Then we have Dr. Vinita Avasthi. She's consultant at Manas Medical Center, Kanpur, Joint Organizing Secretary AICOG 2022-20, and at present she is Treasurer Kanpur ISOPAB. Her area of interest being high-risk pregnancy and infertility. We have Dr. Divya Yadav. She is Associate Professor, SN Medical College, Agra, recipient of several awards, be it the CS Dawn Award for Best Paper, CS Dawn Award for Best Paper in AICOG, and the Best Poster in ISWOG. She's invited faculty in various national and international conferences and his publications in books. A very warm welcome to you, Dr. Divya. We have Dr. Upma Jaiswal. He is FICMCH Director, Swastik Marigold Hospital and Multi-Speciality Hospital and IVF Test Tube Baby Center. She has interest in high-risk pregnancy, obstetric ultrasound, and ART. Warm welcome to you, Upma. We have Dr. Pinky Saxena, Mamta Tyagi. Okay, Pinky Saxena. She's Senior Specialist Obs and Gynae at Deen Dayal Upadhyay Hospital. Recipient of awards, be it the CS Dawn Prize for paper presentation, the APJ Kalam Appreciation Award, and she's a DNB student guide and DNB teaching. A warm welcome to you. And finally, we have with us Dr. Mamta Tyagi. She is consultant gynecologist and endoscopic surgeon, Foxy endoscopic trainer. She is trained in IVF and embryology and owner of the first Foxy endoscopy training center of East Delhi, Best Dissection Competition Award winner, and has organized many live surgery and workshops in East Delhi. She has got the Corona Warrior Award and the Chikitsa Ratan Award. So very warm welcome to you, Mamta. I hand over the session to our moderators to conduct this session.
Thank you, Dr. Babita, for the nice introduction. And I request Dr. Shikha to share the slides. And a very good evening to all the stalwarts, the seniors and colleagues. And before starting this panel discussion, I express my sincere thanks and gratitude to Sadhana Gupta ma'am, Professor Anuradha Khanna ma'am, for giving us the opportunity to be part of this panel. Thank you so much, ma'am. And I always been very guided by Dr. Anuradha Khanna ma'am for especially conducting such a panel, and especially this difficult topic, the maternal sepsis, a silent killer in pregnancy. So Dr. Smriti Jaiswal has made the topic very, very easy for both of us, the panelists and the moderator. And without wasting the time, we will start the panel discussion. We all know that the stalwart, many of the stalwarts have said that you can tell the condition of a nation by looking at the status of this woman. And we all know that maternal sepsis is a silent killer. And it is a huge maternal morbidity and mortality which is burdening our country. So we need to understand this and intervene and diagnose as early as possible to prevent the death due to maternal morbidity and mortality due to sepsis. So WHO definition 2017 has stated that maternal sepsis is a life-threatening condition defined as organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion, and postpartum period. So we have two parts. First is infection, and if we are not treating the infection at the starting stage, there is organ dysfunction, and this leads to maternal sepsis. Next. So we all know that this is a sequence of events: the sepsis, the severe sepsis, and the septic shock. And this is really a life-threatening event, and most of the patient gets admitted in the ICU, and we lose such mothers. Next. The incidence, we all know that it is 11% of the maternal death worldwide and is the third most common cause of maternal death, direct cause of maternal death in our country. And in addition, sepsis contributes to other common causes of maternal death such as hemorrhage and thromboembolism. So while we need to prevent maternal sepsis, it is a priority because we all know that already we are struggling with the PPH and hypertensive disorder of pregnancy. But the third most common cause, the direct cause of maternal mortality, is maternal sepsis, which always received less attention and it needs research programming. So failure to recognize sepsis early, it is a significant cause of preventable morbidity, which results in delayed treatment and escalated care, which are critical if the lives are to be saved.
So coming on to questions now. At the outset, I'm also thanking everyone for all the stalwarts for giving me the opportunity to moderate a panel. Thank you so much. The first question is why pregnant women are more susceptible to sepsis and sequelae? I think Dr. Aradhana ma'am, will you take this question? Dr. Aradhana Singh?
Hello.
Yes, yes, ma'am, we can hear you.
Yeah, am I audible?
Yes, you are audible, ma'am.
Okay. So I think pregnant women are more susceptible to sepsis because of certain changes, physiological changes that predispose the pregnant women to more chances of infection, especially urinary tract infection. And in a pregnant woman, if there is vaginal colonization, that may ascend and lead to chorioamnionitis. And the immunity also is decreased during pregnancy. So these factors favor infection and rapid growth and spread of infection.
Very rightly said, ma'am. There are certain normal physiological changes of pregnancy which actually render the pregnant woman more susceptible and make the sepsis like pregnant. We all know pregnancy is a state where there is hyperdynamic circulation, tachycardia, diminished oxygen reserve, and hypercoagulability. These factors will lead to even more chance of sepsis and late recognition of sepsis in pregnant patient. So, as we know, these are the physiological adaptation we have to keep in mind when we look for the clinical signs of sepsis. Pregnancy is also associated, as we discussed, with hyperdynamic circulation, and this can mask the cardiovascular signs of sepsis. Tachypnea can also be caused by sepsis, which can be confused with the physiological tachypnea in pregnancy. So the next question, ma'am, Sangeeta ma'am.
What are the predisposing factors in obstetrics to sepsis? Dr. Neelam, can you answer this? Dr. Neelam Sodhi, are you there?
No, she is not there.
Dr. Vinita, you can take the question.
Good evening, all of you. First of all, I would like to thank you, Dr. Shardajan ma'am and Dr. Sadhana Gupta ma'am, for this opportunity to me there as a panelist in this prestigious NIG of webinar. And as you asked, Dr. Sangeeta, what are the risk factors for maternal sepsis? So there are certain community risk factors, especially in our setup. There is a low socioeconomic status, lack of adequate healthcare, and lack of trained health professional. And there are certain conditions also which are the risk factor for the birthing condition. First of all, that the birth tried by some die, then some at CSC, then it come to the medical college, but the cesarean. So there are a lot of conditions which are cooperating, which are ultimately predisposing our patient for the maternal sepsis. And prolonged labor, multiple obstetrical maneuvers, number of PV examination during labor. And already our patients are anemic, they have poor nutrition, poor health education. There are certain coexisting infections, HIV and AIDS. And nowadays the diabetes is also very common in the pregnant patient. That all the things make our patient more susceptible for the septic problem.
Very rightly said, Dr. Vinita. Because if we know the risk factors, we can intervene at the right time, and we can segregate these women and monitor more closely so that they cannot land up into sepsis. And the community risk factors, we need to educate the system, we need to educate our healthcare workers to properly for proper low hygiene and influencing these women to take the antenatal checkup more regularly at a tertiary care center. This is very much important. And for doctors during the delivery, this is most important because some of the infection comes in the second stage of labor during the delivery. So we need to understand that the basic hygiene, the proper setup is very much important, and the antibiotics at the right time. So these are very much important, as you have rightly mentioned, the risk factors for maternal sepsis. Thank you.
The next question is to Dr. Divya. Ma'am, can you tell about certain obstetric condition which actually predisposes the pregnant woman towards sepsis? Dr. Divya?
Yes, the obstetric condition starts from the septic abortion and the chorioamnionitis, obviously the preterm rupture of membranes, multiple pregnancies, maneuvers, the placental bleedings, and the obstetric conditions are maybe hyperglycemia of pregnancy, maybe the UTI, which the patients are more prone to urinary tract infections, and the patients are, as the immunity is already low, they are more prone to get gastrointestinal infections and then viral fevers. And the obstetric conditions are, I think, these only, and the other obstetric condition, non-obstetric conditions is pyelonephritis, mastitis, and even the patients come with ear infections in pregnancy and severe pyelonephritis, pneumonitis. The patient comes with pneumonitis, and because of this, respiratory problems also get aggravated because of the enlarged gravid uterus. The respiratory problems are also exaggerated. The lung capacity decreases, so they are more prone for lung infections also, in my opinion.
Yes, ma'am. Very rightly said, ma'am. You have pointed out, we all know that any infection anywhere in the body during pregnancy, actually the pregnant woman is more predisposed. So even a dental infection can lead can lead to sepsis. But obviously, when we study these symptoms more. We know there are direct causes and indirect causes. Direct is anyway if there is leak or if there is endometritis, any wound infection. In indirect causes, we know it could be acute pyelonephritis or it could be even pneumonia, which the patient is suffering from and can lead to sepsis in a pregnant woman. These are again the division of the same infections. Next.
Let us start with the case one. We have a 21-year-old married presenting with 2 months of amenorrhea. She has a history of MTP 5 days back, and she presents with fever, pain lower abdomen, heaviness, vomiting, and giddiness. She has a history of PV bleeding following the procedure and foul-smelling PV discharge. On examination, her pulse was 124 beats per minute, blood pressure 84/50, and temperature is 102 degrees Celsius, which she is drowsy, looks toxic. On examination, her respiratory system, there are bilateral crepitations in the lower lobe, and on there is a mild abdominal distension with absent peristalsis and tenderness all over, guarding a rigidity present. So what is your diagnosis and management? Dr. Upma, can you take this question? Or Dr. Mamta Tyagi? Anyone?
Yes, ma'am. Thank you, Dr.
What is your diagnosis?
For giving me this opportunity. And ma'am, as we can see, she's a primipara young patient of 21 years and presenting with the fever, and she's a history of MTP for 5 days back, and followed by pain, abdomen, vomiting, giddiness, and she's complaining of foul smelling per vaginal discharge. And her mean arterial pressure, which we have seen, is 61.3 millimeters of mercury, which shows that she is in sepsis. And also she is suffering from tachycardia and high-grade fever. And her mental state is also drowsy. That is, she's clear-cut a case of sepsis. And her lungs are also involved, which shows that organ dysfunction is also there. And on per abdominal examination, we are suspecting abdominal distension, guarding, and rigidity, which shows the nidus of infection could be in the abdomen. And since she's undergone MTP 5 days back, we can always suspect either uterine perforation, which she must have undergone, which must have happened, and leading to this condition of hers at this stage. So she's a case of septic abortion with uterine perforation.
So very right diagnosis. So this is very much important to understand. And you have nicely explained. Now coming to the management, you have diagnosed the case. You have a strong suspicion that this is a case of septic abortion with perforation. So how will you proceed with the further investigations and
To assess this case, first we have to diagnose her and we have to see her general condition and her temperature, pulse, BP. This we already know. We have to know her SpO2 and urine output, and also we have to start from examination from top to bottom. And first we have to see her mental status. She's in delirium. We can know her SOFA score, her Glasgow Coma scale. And from breast examination, if it is okay, otherwise she might even suffer from mastitis. Now chest examination shows bilateral crepes, that means the chest are involved. She have to get an x-ray done. And her abdominal examination shows guarding rigidity, and even an ultrasound is indicated for this. And even local examination is indicated, for which we have to do a culture sensitivity, also blood, and also of the high vaginal swab culture sensitivity of this patient to know the primary, so to know the exact organism. And also we can check for DVT and in this patient to rule out thrombophlebitis.
Very nicely explained. We have to go for all the investigations, the routine blood investigations, urine for routine microscopic, blood culture, blood gas analysis because she is going to shock, and blood glucose because sometimes they present with hypoglycemia due to sepsis, and renal function test along with the function test. What is the role of CT and MRI in these? You do CT and MRI in every case, or you just go with the ultrasound and X-ray?
And we can go at CT scan the whole abdomen and pelvis of this patient to know the exact how much damage has been done by that uterine perforation, and also to rule out septic bowel peritonitis and bowel damage if it has been done by that MTP.
Yes, very nicely explained, because sometimes when you do the X-ray or ultrasound, there is a gas. Sometimes gas under the diaphragm, they mimic as a bowel gas. Okay, so it is sometimes very confusing. And in septic patient, before opening the patient, you have to be very much sure that there is a perforation. Otherwise, the patient will land up into more critical stage. So CT is very good in diagnosing the perforation, and there can also go with the endocervical and high vaginal swab with gram stain and culture simultaneously.
Yes.
So very nicely explained. Now the patient is a case of perforation, and you have to go with a laparotomy. But what are the definitive procedures and precautions you will take during laparotomy in this patient? Dr. Pinky, can you take this question?
Yeah, good evening. First, I would like to thank Dr. Sharda ma'am and Dr. Sadhana Gupta for giving me the opportunity. And coming on to the question, like we know already that she is on ultrasound and there is clinical evidence of peritonitis. On ultrasound and on X-ray, we can diagnose if she is having perforation or not. As already said, if there is a doubt, we'll go ahead with CT scan. Now, after stabilizing the patient, building up our hemoglobin, building up our BP, sending all the routine investigation, we have to take the patient up for laparotomy. Here, I would like to stress on the fact that we have to give a good IV antibiotic first shot before taking up the patient for laparotomy. So we have to adhere to the sepsis 6 bundle, So one shot of good IV antibiotic, like in this case, we can give either Piptaz or Meropenem, is very important. Resuscitate the patient. Take the patient up for laparotomy. Again, here for medico-legal purposes, if you are suspecting that there is perforation of the bowel, always call your surgeon colleague so that there is no problem. You do a very gentle gut exploration. Whatever perforated site is there, along with the surgeon, you can do resection anastomosis. If required, colostomy, whatever is required, depending upon the injury that is there. Clean up all the, debris and necrotic material. Give a good wash if you want. and then you can put in a drain. So all these are things you have to take care. And remember the dissection in this case also, you don't have to be very rigorous, because the entire tissue is very edematous and friable. So you have to do a very gentle dissection along with the surgeon.
You're absolutely right. You have well explained the management during laparatory. The most important thing that a senior obstetrician should be involved always, along with the surgeon. And most commonly, you have a lot of necrosis, lot of edema. So gentle bowel exploration, as we have mentioned, and you have to break the loculi and the drainage of the pus. And this is very much important. And the necrosis tissue should be debrided because the chance of gangrene if it is present. And then the closure of the uterine perforation, if it is okay with you, if the patient is a primary gravida, you need to conserve the uterus. But if the uterus is necrosed totally, then you can go also with the hysterectomy in cases. And rest we have explained nicely. What are the indications to transfer to ICU? Because already I have explained, this is the case of septic shock. Yes, so we need to admit the patient in ICU. But in your conditions, what are the indications, the system indications where you will go for ICU admissions? Because already we have limited ICU beds available. So what are the indications? Anybody can take up this question?
Good evening, everyone.
See, as such, this patient is come on day 5. Perforation has already occurred 5 days ago. Now she is having bilateral Krebs also. That means that she is already toxic. If you can see the SOFA score also, it is more than 2. Even the proper, the modified SOFA score is more than 2. And even the SOFA score, if we do, is more than 7, So this patient will definitely require an ICU care. There's no doubt about it. Because once the bowel has been perforated, lot of microorganism, toxic microorganism is released, So definitely this patient requires ICU care without any doubt, at least for this patient.
Very good. So there are a lot of indications because any of the system like cardiovascular system, respiratory, renal function, neurological system or multi-organ failure is there with uncorrected acidosis and hypothermia, you need to admit this patient in ICU. Now coming to the case 2, 30 weeks primary gravida presented with watery PV discharge for the 3 days in emergency with pain lower abdomen and fever. On examination, she is conscious. Her pulse is 120 beats per minute, BP 90 by 60, 101.4 degree in Fahrenheit temperature, 28 per minute respiration, and on per abdominal examination, her uterus is 28 week size with vital heart rate of 128 per minute with fixed vertex. For speculum examination, there is a blood stain discharge and flying click was present. And on PEPI examination, the cervix is 2 cm dilated, 30% effaced, and the station is -2. Membrane was absent and there is a hot vagina, but there is no foul smelling. So what is the diagnosis of this case and then how will you proceed? Dr. Aradhna, can you take this question?
Yeah, this is probably a case of chorioamnionitis. Because we are getting all the signs of infection. She has leaking for more than 24 hours and she's dilated and there is also tachycardia and there is frank leaking and vagina is hot. So here the infection has a certain inside the uterus and there is chorioamnionitis.
Very likely.
The patient is also having
PRN. Yes, with chorioamnitis. So when you just get this patient, she is just 28 weeks fundal height and the vertex is fixed. She is already in early labor. So how will you proceed for the further management?
See, the definitive treatment for chorioamnionitis is termination of pregnancy. So we definitely have to terminate and speed up the process of termination. Meanwhile, we resuscitate the patient and take care of infection and sepsis she is developing. So a good broad spectrum antibiotic, IV antibiotic is to be given to the patient, to the woman, and IV fluid crystalloid, as madam has said, 30 ml per kg within a bolus within 3 hours, and oxygenation if that is needed, then oxygen support is to be given. And again, the fetal monitoring, proper fetal monitoring is to be, and labor has to be, if the patient is already in early labor, and we can augment labor. So,
very rightly explained.
So basically,
because these cases we need to
patient.
terminate the pregnancy. Yeah. So do you send high vaginal swab in your every patient?
Yes. Yeah, but in this case, patient is frankly leaking. So when there is frank leaking, you see the liquor washes out all this thing, bacterial flora. So if there is no slight leaking or no leaking, of course we will send vaginal swab, high vaginal swab for culture. And before instituting antibiotics, ideally it should be begin within 1 hour, and before starting antibiotic, blood culture must be sent. So,
very rightly said, because she's hardly 28 weeks, but she has developed chorioamnitis. So this is one of the indications to terminate the pregnancy, and here prognostication should be done regarding the fetal prognosis. So here, do you think there's any role of steroids or Maxel or any conservative management to prolong the pregnancy?
According to WHO, steroids should not be given in case of chorioamnitis with prematurity. So here it is not recommended to give.
I want the opinion of experts.
Ma'am, and
Only
because the patient is 28
this
weeks.
case, the fetal tachycardia is not there, and the tachycardia fetus, the heart rate is 128, and 28 weeks, very salvageable fetus, and we can also assess this patient after 6 hours to see how she improves. If her tachycardia improves, we can always wait for 24 hours at least for the steroids to work, and we can also give simultaneously injection magnesium sulfate to improve neonatal for the brain of the neonatal, and then we can, because this fetus is salvageable, and we can prolong, if we want, we can prolong the pregnancy at least for 24 hours, and then we can do we can carry on with the labor, but we should not use any tocolytics, because it can further exaggerate her lungs. Edema it can cause.
See, here you can do few investigations, like you can do CRP, you can do WBC, you can do urine routine, just reevaluate the patient in this case, because she is borderline, So if there are signs of sepsis, like the CRP is positive or your procalcitonin is positive, right? Your urine routine microscopy is showing certain organism, so that is a predisposition for chorioamnitis, there is tenderness, you have to evaluate whole, and if you suspect chorioamnitis, you have to terminate the pregnancy. Definitely you can give magnesium sulfate for protection, that is there. You have to say, should you give steroid or not. In frank chorioamnitis, I don't think we should give steroid. It will flare up just for lung maturity. Either later on, the fetal can be given surfactant also. So this is a very debatable point. If it is not frank chorioamnitis, the WBC is not very high, and all that, then you can give steroids. But delivery is definitely required.
Delivery is inevitable.
Very, very clearly.
See, there is a clear-cut recommendation by WHO that antenatal steroid should not be given to women with chorioamnitis with preterm pregnancy going to deliver. And it should be avoided in cases of ongoing systemic infection. So this is a very clear-cut guideline from WHO. It should not be, steroid must not be given.
That's what I was saying. If you do a CRP, it is positive, WBC is elevated, there is uterine tenderness, definitely.
No, but there are signs of chorioamnitis, clear-cut signs. You, on the basis of clinical feature, you are diagnosing.
Ma'am,
Yeah, you should not.
amniotic fluid, it is said it is not purulent, it is clear amniotic fluid.
There's no false smelling.
Amniotic fluid that does not be purulent, you see.
Yes. So that's why
Even if it
you
is
need
not
to
foul
understand
smelling,
that
patient
it is
has
a
fever.
borderline case. We have to
No,
be
the night is also hot, so I think in this case you should not give steroids. Depending
any
on
opinion for
Because you
expert.
flare up by giving
Actually,
steroids.
this is steroid is always what I think that it is always a lot of thing is happening about it after this that it is not to given after 35. But what Aradhana says, this type of when there is a chorioamnionitis, steroid should not be given because it can increase the sepsis. So there is like a important thing that steroid is not to be given. Important thing is that we must understand the spectrum of chorioamnitis. What Shikha have taken, this is a something clear-cut sign. But in our clinical practice, what happened, patient is coming with the PROM, and when she is developing chorioamnitis, that is the tricky thing. And in this situation, what he says that the maternal tachycardia, maternal fever is the 90%, more than 90% sensitivity for the chorioamnitis. Basal leukocyte count and the increase of the leukocyte count like around 15 to 30%. Side by side, the fetal CTG is also important and the fetal movement count. So if the patient with the PROM is coming and the patient says, now today I am having a very, very reduced fetal movement count, that is also sign of the chorioamnitis, and that is also sign to the terminate the pregnancy. So in this, like a frank thing, which is a hot vagina, it is almost chorioamnitis. Steroid is a big question mark, though of course there is gray area because we really want to say that it has certain benefit to the neonate, but what Aradhana says that in frank chorioamnitis, it is not usually desirable to give the steroid. Dr. Sharda, yes.
Just I would like to say,
yes, Dr.
PROM itself causes lung maturity.
Yes.
Not required.
Yes.
This is the best thing that any PROM, whatever the reason, it causes lung maturity. Steroid is never required.
Thank you, madam. This was I was just about to say that the any leaking enhances the lung maturity.
Yes.
So we get better babies out of it.
Yeah, no need of steroid.
Thank you so much, ma'am.
I fully agree with Dr. Aradhana. I will fully agree with Aradhana that the steroid should not be given in this case. And Madam Khanna has already said that whenever there is a leaking, you can find that these babies do not really pose a problem. And secondly is that this patient, after observation for almost 12 hours, once you find that the chorioamnitis has set in, there is a need for termination. We need not wait till 24 hours in this particular case, and she requires an augmentation simultaneously.
Thank you, ma'am. Thank you so much for your expert opinion. So it's very clear this patient doesn't need any steroids because she's already in frank infection and we need to deliver the baby. This is very much important with proper prognostication of these patients. So coming to the key interventions to prevent the maternal sepsis in these group of patients. Dr. Vinita, can you just highlight some points how to prevent the maternal sepsis in these group of patients, especially coming with PPROM or PRO?
Yes, we have to maintain the aseptic practices during the birth and perform the rigorous hand washing, especially during the birth, and minimal use of the invasive procedures. And especially when the patient comes for the antenatal checkup, we should screen, at least ask for the genital infection. Sometimes patient is already having some infection and that will travel up to the upwards and it make the leaking and the chorioamnitis. So, and the vigilant for the endometritis, especially in the during postpartum period, if patient says some pain in abdomen, tenderness, so we have to carefully watch and examine the patient, especially the postpartum period, and always ensure patients. We have to teach all the warning sign of infection to the patient at the time of discharge. So if she has some problem, she can come as early as possible to the hospital.
Mamta has not. One thing I want to have I think panel have discussed that, and that case, what your panel's opinion about the mode of delivery? Will your preference for immediate section or your preference for the induction of labor? This is something.
Normal delivery, ma'am, as far as possible, because already vaginal route is infected and the fetus is also already in the infected stage. So we want for the normal delivery, do not wish to open the abdomen and to just to flare up the infection. If normal delivery is not, we cannot wait for very long also. So we have to, but otherwise the preference is normal delivery.
Any difference of opinion? I think there are.
I would like to say, like, you can't wait for 24 hours.
Yes,
This
yes,
is already set in. So
yes.
if the patient you feel is not gone into established
Delivering properly, yes.
maximum within
Yes.
6 hours, I will not wait beyond that. I will give initially I'll give a good shot of antibiotic. I will not prolong it up to 24 hours. If the patient has got into established labor, she is dilating, she is having good uterine contraction with augmentation, fine. Otherwise, if she's not gone, maximum I'll wait is 6 hours. After that, I will definitely inform the patient's relative about the prognosis that, look, if I leave the baby inside, there is danger to the mother. And in the interest of mother, I would definitely like to do a cesarean section for her. I will not wait for
what I will say, it is even for the neonatal, I say 28-week babies today are salvageable in our setup. It is 28 week is quite a fair time of maturity. And the two things why I put this question, because that is in the interest of fetus as well, because we have a better, if you have to have a look on the fetal distress, that is a reduced fetal movement, what is week to week variability. And the second thing is the neonatal antibiotic protocol. That is goes hand in hand in chorioamnitis, that the neonatal antibiotic, that is a suspected chorioamnitis, isolated fever, or it is a proven chorioamnitis, and that has to have a tailored neonatal antibiotic protocol, that it is for the 5 days or it is IV antibiotics. That's why I put this question, that in chorioamnitis, because many times you will find a much worse baby if you wait for 24 hours. So sometimes you have to take decision. It is not so that the cesarean section always sepsis. You have a good outcome also. So you have to take a balanced decision in taking overall picture. Mamta, Mamta was going to say, so we will have the next case to the Dr. Mamta Tyagi. She is there. So
one thing, Dr. Sadhna, that this infection, any infection, is a cause of cerebral palsy in the newborn. So that is very critical. So we have to just discuss with the parents, the guardians, that look, this is the situation and there is no harm in getting cesarean done.
Yes.
To save a cesarean in such a situation, at least I put that if it is my daughter, I will like to take out the baby, because 28 weeks is good enough to save the baby nowadays. And she can have, the baby will have a good environment, baby have a better detoxified effects. So I will like to go for cesarean. And the same way we have to counsel and discuss with the party. And then we go ahead. That's what I do.
Thank you, ma'am, for such a nice explanation, because the counseling matters much in this case. And counseling the parents and a proper NICU facility, if it is available, then better to go for cesarean section to save the life of the baby. Dr. Shikha, proceed with the next case.
So this is the next case. This is Mrs. X. She's 25 years old. She's Gravida 4, para 3+0 life free at 30 weeks of pregnancy, and she has presented to you with fever. On taking the detailed history, Mrs. X says that her fever is continuous, though she has never recorded it. She is experiencing chills with fever, and there is no history of cough, cold, or any rash which is associated with the fever. But she does complain of dysuria and hesitancy. When you physically examine Mrs. X, she's having tachycardia with a pulse rate of 110 beats per minute. Her BP is 112/60, temperature is 101 degrees Fahrenheit. Pallor is present, chest is clear, breasts are soft, and there is tenderness in right lumbar area. There is no calf tenderness. Abdominal obstetric examination shows all the findings are normal. So the next question to Dr. Mamta: what is the probable diagnosis?
Thank you, Sadhna ma'am. Thank you, Sharda ma'am, for giving me this opportunity. In this case, as per history and the examination finding provided to me, most likely the patient is a acute pyelonephritis, most likely. But I will like to confirm my diagnosis with the investigation, supporting investigation, like CBC, KFT, and the TLC counts and ultrasound. Then I will proceed accordingly.
Very rightly said, ma'am. This is the case of UTI, and she's having lumbar tenderness. We could say this is pyelonephritis. And you rightly included. Can you elaborate a little? What will you include in your initial assessment of Mrs. X and Y?
When we are starting any pregnant patient with the fever, we have to think all the diagnosis about the fever. That could be the something with the viral fever, something with the bacterial or the chest infection. But as per history and the finding you are providing me, that could be a case of some ovarian or something in the adnexa. In the basically the patient is having pain in the lumbar region actually, because many times what happens, the pain in adnexa refer to the lumbar region in the pregnancy, because the area changes according to that. But the ultrasound finding may suffice us that whether patient is having any renal stones, something like that, or the urinary stasis or infection.
Yes, ma'am, very rightly said. We actually, whenever we examine a patient, we go with a routine. We do a detailed physical examination, also take a complete history. Here, dysuria along with lumbar point tenderness, which is at the thinking it may be renal. That's why we went with the diagnosis UTI with pyelonephritis. I think that's what clinched the diagnosis for us. Now, the causes of fever, as you said, we have to elaborate here. The fever was continuous; it was not intermittent, so it does not goes with other. But if even after instituting the antibiotics and other, it does not subside, we have to go for other investigations also. The next question to how will you manage the case? I think Dr. Upma has. Okay, ma'am, if you want to take the question.
No, it's okay. It's okay. It's okay. Dr. Upma can answer. No problem.
Dr. Upma has the turn now.
Yes, ma'am, since it's a case of urinary tract infection with pyelonephritis, we have to ensure that she takes adequate rest and she needs IV fluids to maintain urine output in the normal range. Her urine serum creatinine should also be measured to see that she doesn't suffer from acute kidney injury. And IV antibiotics, broad spectrum IV antibiotics are the mainstay, and we have to instill it after taking blood for culture sensitivity and also urine for culture and sensitivity. And urine analysis will also give us an idea about the magnitude of infection. Like we can see whether there is hematuria also in the urine, and if there is sometimes asymptomatic, if she has a history of recurrent urinary tract infection, she could be a candidate for even further investigation, for which we have to do asymptomatic bacteria in pregnancy, which can also flare up during pregnancy at this gestational age. And even it can cause neonatal sepsis also later on in the neonate. And for that, we have to take a urine culture for it is that there like 1 lakh bacteria are found in 1 ml of urine. And that is very diagnostic of asymptomatic bacteria. And the mainstay is heavy antibiotics for this patient. And since most of the times it is E. coli and Klebsiella, E. coli is the most common organism which can cause, and for this we have to give it we can give vancomycin to these patients.
And starting off antibiotics was very rightly done by Smriti ma'am, as she rightly pointed out. First we start with the basics and then we go for other antibiotics. You have very nicely explained what has to be done. You also need to counsel this patient and her attendant. What happens sometimes, the attendants will say that we only brought this patient with fever. Now, if she goes into labor, preterm labor, she has a high chance for.
It's very high chance of.
Yes. So this has to be explained, and the continuance of antibiotics has to be done. Patient, as you have very rightly explained, that asymptomatic bacteriuria or recurrent UTI has to be investigated in pregnancy. So this very much explains this case. Coming on to the next case scenario. This is a case of 35 years old Mrs. X. She's para 0+3 and she has come to your OPD with fever and chills, weakness, abdominal pain, foul smelling vaginal discharge for the past 24 hours. She had given birth to a full-term infant at home 48 hours ago, and her birth attendant was the local traditional birth attendant. Labor lasted for 2 days, and the birth attendant had inserted certain herbs into Mrs. Rupa's vagina, Mrs. X's vagina, to help speed up the childbirth. The newborn breathes spontaneously and appears healthy. When you physically examine her, her temperature is 39.8 degrees Celsius, pulse rate is 136 per minute, blood pressure is normal, respiration is 24 per minute. She appears pale and lethargic and slightly confused. Abdominal examination shows a poorly contracted and tender uterus that is just 1 centimeter below the umbilicus. An examination of the perineum shows that she has foul-smelling vaginal discharge, but she has no tears or lesions. On vaginal examination, the cervix is 2 centimeters dilated with cervical motion tenderness present, and it is not known whether the placenta was completely out or not. Mrs. Rupa is fully immunized against tetanus and had a booster 3 years ago. So what is the diagnosis of Mrs. X and why?
So
Dr.
this is a
Vinita?
case of puerperal sepsis.
Yes.
Yeah, Dr. Vinita. Yes, ma'am.
Yes, because she first in the history, she's have a home delivery with some uneducated person, and there is history of some insertion of some herbs or something else. So and there is a on examination, fever, tachycardia, mental confusion, all the signs and symptom of sepsis. So just to manage this patient, we have to admit this patient, send all the important investigation like CBC, SGPT, and liver kidney functions, and we will do a scan also to confirm whether the placenta is expelled or not. There may be some retained product of conception, so we have to rule out this also, and give the general the broad spectrum antibiotic, fluid management, oxygen, and all the supportive treatment we will start, and according to the condition of patient we will step up the treatment, and we can send a blood culture also for the if the patient is not improved with by giving antibiotics, especially we are giving, so we have in hand the blood culture report, so we can step up for the further antibiotics.
It's a clear-cut case of puerperal sepsis. So we obviously initiate the sepsis bundle, which was very detailedly dealt by Smriti ma'am. And as you have already pointed out the components of the bundle, these are the things that we look for. We do a rapid initial assessment, and then we ask her about a detailed history. And important points about delivery are also taken. And investigation also you have dealt, ma'am. So we won't do, but we have to do a detailed per abdomen, per speculum examination in the same patient. Even look for calf muscle tenderness.
Or if there is any foreign body, we have to remove that. So
exactly,
when we are doing the local examination, we can find out what the
because she had
it happens sometimes even at the CSC PSC level, even at the by the qualified birth attendant, sometimes there is a sponge or any foreign body can be left in the vagina. It happens so many times, and patient come with these symptoms with the foul smelling discharge and fever and tenderness, come to the OPD and in the hospital also.
Very rightly stressed, ma'am. That's what
also ultrasound scan of this patient is required after stabilizing her to know whether the placenta is left inside or not. For that, which we have to do a manual removal of placenta.
Yes, ma'am. So it was important to stress here that you need a detailed examination, and then coupled with the investigation, when you know the delivery was conducted by a traditional birth attendant. So this will. So what are the risk factors for maternal sepsis
At this
in
moment,
puberty?
I really wish I was to interrupt Shikha, just
Yes,
to
ma'am.
have a panel, because like the what we say with the JSY, which our country is very much proud of. Really, in private setting, there has been a lot of reduction. Like we really don't have such cases. So I really want to have Divya, Vinita, like who are Sangeeta also, like you are in the medical college, because there has been the drastic reduction. India is not that We are really going to have a developed country, and we really feel that we don't now find that case, but we find unusual cases of sepsis, like cervical circulation, like IVF pregnancy with low immunity, with medical comorbidity. So just because we want to learn from the experience, so Divya, especially Vinita, what your experience? To me, it is very much down. We don't get so much bad cases now, but we have the different type of sepsis nowadays, and that makes the thing, our diagnostic thing, difficult. So we want your input, that what has been the change. I'm sorry, just because I could not check.
No, ma'am, it's pleasure to share our own experience, because when you are sharing your experience, you need not to read it. I'm a private sector, but still I'm getting this type of patient. I have got a patient after 1 year of delivery, some CSC. She came to me that something is coming out. So initially I thought it must be some prolapse or some cervical descent because of the normal delivery. I was not aware कि ऐसा कुछ होगा. When I examined the patient, that was foul smelling. इतना बड़ा gauze was there. For the last 1 year, she was having that problems, and then I remove it. You can imagine what type of smell and what, and she is having. And nowadays, even in the city, patient is having home delivery because of fear of cesarean at hospitals. So they are still coming with the sepsis, because sometimes they have leaking, going to hospital, coming back, then had home delivery. Then lot of things are still going on. They are coming with this problem. Even when we are doing cesarean, patient come after the trial with dye or someone else. So we are also getting this type of patient of sepsis in our setup also. It happens when we are doing. Yes, ma'am. Last week I have done the cesarean. The initial she was some cough cold problem. Then blood pressure was higher side. So we did the cesarean. PIH was there. Third day onward, she and the OT she landed up in the pulmonary edema. She was shifted to ICU. Third day her count was 23,000. Then we start meropenem and dialysis, and fourth, fifth day she was all right. But if clinically she was not having any sign of some sepsis or all the problems, सिवाय थोड़ा सा fever वो भी 100. It may be due to because when we are giving for pain, paracetamol, all the things, symptom may be masked. So still patient is there. Still the problem is there. Though one more important part is there, the patient is more of the patients are coming with a gestational diabetes, and they are not managing it. In spite of counseling and everything, they are taking sweets, chena and everything. So even borderline blood sugar is raised. That is again susceptible to patient for the infection. So we are getting it.
That is a matter of concern, Divya, because now to me, this is the quality care in the JSY certified hospital. That is a quality and the retained swab and sponge, it happens in medical college also. So because so much of our, so it is nothing like we say, but the quality in the JSY and the NRHM certified is something we have to deal with. Divya, in your medical college as well as what's your?
Ma'am, thank you so much, ma'am, for inviting me, and it's a pleasure to speak in front of you and Manju ma'am and Sandhya Jain ma'am. And ma'am, actually this type of puerperal sepsis, we are getting more of septic abortion these days, because the government is becoming more stricter about the abortion care, and still people are going to, they are getting second trimester abortions, and some ladies are even self treatment, they are taking the MTP pills and they are aborting themselves. So septic abortion cases are more common, and in case of puerperal sepsis, instead of endometritis, what I see more cases of pneumonitis and pyelonephritis, which I have seen myself. And yes, ma'am, that is true that involution and cervical motion tenderness, these cases are becoming less because of your blessing.
Thank you. Because actually, the new things are, and the pyelonephritis, I think panel have done that, because it has, she has to be admitted and the IV antibiotic followed by 7 days antibiotic. This is something, and always for the recurrent UTI, give the long, like low dose antibiotic prophylaxis. Why the patient is going through the pyelonephritis? Because we are really missing the recurrent UTI, and these patients require chronic low dose antibiotic throughout so that we prevent the pyelonephritis. So we have around time to finish.
And
Shikha,
sometimes for pyelonephritis, we have to give throughout the pregnancy and even in postpartum period.
Yeah, low dose prophylaxis has to be given sometimes.
Yeah, continued throughout.
One point I would like to
Also,
say.
3 years experience?
Yes, ma'am. Yes, ma'am.
Yes, Dr.
Yes.
Anuradha. After
Yes, actually, if you see the practice PowerPoint of, though not mentioned in the books, about the genitourinary tuberculosis. Such patients, those who are having recurrent UTI or having pyelonephritis, what we are seeing is the second organism, like Klebsiella, Pseudomonas, or E. coli, whatever. But sometimes, even if you treat it, becomes recurrent off and on. And in our scenario of Uttar Pradesh, we are having high prevalence of genitourinary tuberculosis. So just I made it because after recurrence, I have seen that in such cases, though it is very difficult to diagnose, but if we start putting her on levofloxacin, something like that, if she is not pregnant, already pregnancy has been terminated, then we see the response is there. And again, ESR is of no value in such cases. And this coming the genetic code possibility. So that is also not being diagnostic. So we have to see patient in toto and suspect the probable genitourinary tuberculosis, and we can start with the urologist discussion about the antitubercular treatment. This is just my share, which I do, and sometimes I found it, yes, it is very useful.
And Madam Dr. Sharda.
Yes. I will just share my last 50 years experience as a gynecologist.
Yeah.
I did my MD in 1973 and spent 23 years in the medical college. And now for 30 years, I'm in practice. I will say that, seeing best of the both worlds. In Lady Hardinge Medical College, there was a septic ward. In PGI Chandigarh, there was a septic ward. When I left medical college, Lady Hardinge Medical College, the septic ward in my time had disappeared.
Yes.
So there were a lot of changes in 2000. In 1990 itself, the septic ward had changed completely. Now, what I find in practice in the last 30 years, PPH has remained a problem. Who is going to create a problem for you? You do not know about it. As far as hypertensive disorders are concerned, in my practice, no eclampsia cases. And I think, with the antenatal screening for PET and giving them, aspirin, you find even severe cases of, PET have disappeared. And sepsis, I find, the spectrum is very different. The spectrum is, sometimes you can find that a bad sensor cerclage has been done, you can find there is a sepsis, or the UTI which has not been handled very carefully, there's a sepsis. But the medical disorders complicate more problems. I find, sepsis as a problem has disappeared. And I will fully agree with Dr. Sadhna. The scenario of the healthcare has changed in this particular country. I work in the capital of this particular country and see the upper middle class and the higher class of patients. I find, these probable things have disappeared. It's the medical problems which are creating more problems. It's the PPH which is the main problem. Hypertensive disorders don't bother us. Infections don't bother us. Because I think, once you know what is sepsis means 6, you have to have an early diagnosis, early investigations, early use of antibiotics, monitor them very closely. I should see that patients should settle down. And this is what I find the spectrum about it. But I think, Dr. Agarwal's presentation had been absolutely superb. And that particular thing has been highlighted. I think the case discussions have been absolutely great. We don't see bad cases at all now. We just don't see them.
Thank you, ma'am, for the input. Definitely, we don't see cases like these now, but we presented a classical case in our panel just to have the diagnosis and the import. We wanted to stress on the importance of a detailed history, clinical examination, and a good PS and PV examination. All Sepsis bundles and everybody talks about institution of antibiotics, lactates, and everything. But you have to examine the patient in detail before doing anything. And that's why we put a classical case here, which is not quite common now. It's good for us. So coming on to the next question. Dr. Upma, will you take the question? What are the risk factors for maternal sepsis in puerperium?
The risk factors for maternal sepsis are as usual.
It is already 7. You must wind up.
Okay, ma'am. Then we'll wind it up.
Yeah,
we already discussed what are the common pathogens. Our plan of management will be start institution of sepsis bundle. This is a next case scenario. If you think, ma'am, we can leave this case, or should we wind up?
Great clinical presentations and meetings are in start in time, finish in time.
Okay, ma'am. So we'll come to the summary, ma'am. We were also talking on wound infection. Ma'am, Sangeeta, ma'am.
Yes, can you identify this?
Mamta, Shikha, we can take one line message from every panel how to prevent sepsis. Though, ma'am, say, what I say that the changing disorder like appendicitis, few things madam has said, na medical disorder also add to sepsis. So this is what Shikha is saying, that the GDM, obesity, which is on the rise. I think, Shikha, we can take one line message from every panel. For prevention and the treatment of sepsis, and then we can conclude.
Sure.
Yes. So put the last slide.
This is the last slide, ma'am. Should I go to thank you? This was the summary of us. I request panelists to just summarize the panel in one line, as Madam Sadhna Gupta ma'am said. So, Dr. Aradhana.
Yeah. Thank you, ma'am. I would like to give a message that QSOFA scoring is a very simple scoring, and that must be done, and we should put in our have to do practice this QSOFA scoring by respiration rate, GCS, and systolic blood pressure of less than 100, and any 2 or more of them predict or indicate sepsis. So this is simple scoring for low resource setting, and we should go by this.
Dr. Vinita?
Whenever we cross our septic patient.
Early diagnosis and aggressive treatment is the key for success for this septic patients.
Dr. Divya? Okay, Dr. Upma?
I would like to say a stitch in time saves 9. Be vigilant all the time. Since the patient has come in contact with us and since she leaves us, and after that, we have to be vigilant at every step.
Okay. Dr. Pinky?
Yeah, so I would like to say we should know our bugs. What are the common microorganisms? Try and initiate antibiotic within 1 hour. And slow escalation of critical care is very important to prevent sepsis. So stepwise escalation of critical care.
Okay. Dr. Mamta? I request Sangeeta ma'am to just summarize and conclude. Sangeeta ma'am? Sangeeta ma'am?
Divya wanted to say something.
Yes, ma'am. Early diagnosis and broad spectrum antibiotics and working as per protocol. That is, I think, that is the best part. That is most important. And
so
with the ICU facility,
all the panelists
bystanding.
Yeah, thank you so much for your valuable inputs. And under the guidance of experts, yes, we can prevent these cases, and always the prevention is the key. By using the safe delivery practices, judicious use of antibiotic prophylaxis, vaginal cleaning with povidone previously, we should do in every patient for LSTS. We have to first antibiotic bacteria during pregnancy. We need to know understand PRM, PPRM. So these people should be genuinely checked for the cause of infection So we have to counsel this patient, check for the crack people, and do start the antibiotics, and yes, screening for GBS and the treatment. So thank you so much, everyone, for giving time for this. Thank you. Thank you for co-moderating this session.
I want to say one thing here is that is there still a concept of aerobic infection and anaerobic infection? The coverage should be given for both of them, or it's only any antibiotic that has to be given?
It's there, very much there.
The
anaerobes should also be covered as far as I think it has to be.
Yes, ma'am, definitely.
Whenever antibiotic
Very
therapy
important.
cover
Again,
both
this is
aerobes and
polymicrobial infection.
Yeah, madam, always it is a MP Genta, either Metrogyl or clindamycin. So anaerobic has to be covered. But in our routine lab practices, we are not doing for anaerobic culture. What I find that we have a routine culture, but anaerobic. But in antibiotic coverage, we definitely give. And the one very important thing is the abuse of antibiotic, because we are using so much of antibiotic for so many things, and that is causing actually. Dr. Sanand, right now, like they say that we are able to save the hemorrhagic patient, we are able to save hypertensive, but we are not able to save the septic patient because of very, very high antibiotic resistance.
Every Tom, Dick and Harry is using.
So yes, so the right antibiotic practice in our routine practice, what we say for the simple fever, viral fever, we have to be very, very careful about it.
Fully agree with you, ma'am. A simple antibiotic
what Sadhna has managed, when Sadhna has said, when sepsis has got an organ involvement, the mortality is almost 20%. And when she has a septic shock, the mortality is almost 40%. So this we should not forget. And here I must request each and everyone that outside, whether it's Europe, England, America, anybody who practices obstetrics have to do a critical care course every year. They have to be certified every year. And this is my request to each one of you, that Delhi Gynecologist Forum runs a wonderful critical care course. There are 10 modules in it. And I think, my boss says that till the time 500 members you have trained, we will not increase the fees. The fees has been subsidized to 33%. And I think we have trained more than 330 people. We have already trained. Majority of the people are medical college and private practitioners. So this is my request, that before you say, you must train yourself. You must update yourself. There is no confusion here in your mind. It should be there. And that is called what is the training. Even Narendra Modi says that, why Indian doctors are preferred, why Indian engineers are preferred, because they stick to the lines and manage their cases. So my request to each one of you who's practicing obstetrics is that, you should do critical care course. So with that particular thing, thank you very much to Sadhna for involving me, and myself knowing so many senior people and younger people. And I think, I will definitely note down the numbers, and sometime I'll bother you that, what is going on at your end. So I think I was very happy with an academic exercise which had been done today.
Yes, ma'am, I have joined your course. I would like to add here, it is a wonderful course. That critical care.
It's a wonderful course.
Yes, ma'am, I have joined it, ma'am. I have joined it. It's excellent. Very nice course. Yes, ma'am. I did it.
People, Dr. Urmil Sharma says, we will not increase the fees. So this is an opportunity. Our course is currently going on, and it's going to again start in September. I will give you the dates.
That will be very good, because
once a week module for 3 hours.
You have to have it online also. The person has to be.
Is it online?
It is online. It is online. And the
what
timings are from 3 o'clock to 6 o'clock.
What is the
timings are from 3 o'clock to 6 o'clock.
Course fee?
Ma'am, please share the details on WhatsApp, please.
Course fee?
Yes, I will share the details.
Yeah.
I will say that you must insist all your postgraduates. You must insist all your senior residents. And it goes without saying that anybody, a private practitioner who is conducting 5 deliveries a year, must do this particular course.
Because we get it done in the conferences, and that's a one-day time. And then I think whether that is sufficient or not, I don't know.
Ma'am, we teach out of the world.
You have to have
we teach out of the world. Nobody can surpass us.
Thank you.
We are very clear.
Madam will
every course which we
I want the details.
I want the details.
Course. I want the details.
So,
We'll send you
Babita, yes, before you go to vote of thanks, I thank everybody. And today we have a really great start of UP chapter of NIGF, and we will make, we need everybody mark that we will make the faculty pool of every state of North India, so that we have the like a joining हमारा karma बढ़ते जाना चाहिए. और मैंने ग्रुप में डाला है NIGF Facebook पेज पे, जहाँ पे आप वेबसाइट पे अब you can get the instant registration. So we have a lot
डॉक्टर शारदा, मेरी आपसे रिक्वेस्ट होगी, जैसे आप आपने ये ब्लू बनाया ना, पंजाब का दूसरा कलर देना, हरियाणा का दूसरा कलर.
जी. Yes.
And Madam Secretary has said, you know, involve the medical college. That is where the crux lies. बड़े-बड़े लोग तो पीछे नहीं जाना, हम तो नीचे से शुरू करेंगे. Teach them, you know, all courses are there. Teach every MBBS doctors anemia मुक्त भारत. उनको सारी चीज वही रटानी है जो उसमें दी गई है स्लाइड्स के अंदर. बस उससे ज्यादा उनको जानना ही नहीं है. पोस्ट ग्रेजुएट्स को भी उतना ही जानना है और करना भी उतना जरूरी है. हम लोग भी नहीं करते जो उसमें दिया हुआ है. Such a simple slides which the government of India has shared. They want uniformity across the country. Across the country, you must speak the same language.
Babita, this is time. We are just 13 minutes late. 13 minutes late, only 1-3. So it's great. Babita, you can go.
मैडम, मेरा सेशन है 8 बजे डॉक्टर साहब, इसलिए मुझको जरूर जाना है वहाँ पर.
Thank you, ma'am.
Thank you so much.
Thank you, ma'am, for giving us. Thank you.
So we started today. Our session was interesting with a very brainstorming topic of maternal sepsis. We had some discussion of beautiful cases of panel. I would like to thank President of NIGF, Dr. Sadhana Gupta ma'am, and of course, Dr. Sharda Jain ma'am. Ma'am, we are very impressed by your critical care course and we promise to join it. Kindly share the details. I would like to thank
डॉक्टर, आप कैसे कह सकते हैं आपने कोर्स अच्छा है? जब तक आपने देखा नहीं, करा नहीं, सुना नहीं, तब तक आप उसको अच्छा नहीं कह सकते. आपको जानना जरूरी है.
आपसे सुने हैं इसलिए अब करने का मन है, हम लोग जरूर करेंगे.
हमने तो करा है ना, बहुत अच्छा है.
And I would like to thank our revered guest, Dr. Anuradha Khanna ma'am, for taking out a precious time. Ma'am was present throughout and she gave a wise inputs in between. That was really very nice of her. I would like to thank our speaker, Dr. Smriti Agarwal ma'am. Her talk was very concise and to the point. And our chairpersons for this session, Dr. Sarveshri Nautiyal, Dr. Sadhana Jaiswal ma'am, for conducting the session so very smoothly and giving their wise inputs on that topic. My thanks, sincerest thanks to our moderators, Dr. Sangeeta Rai and Dr. Sikha Sachan, for presenting such beautiful cases in such a short notice of time. The topic was difficult, they were apprehensive, but then the case presentation slides were really, really good. My sincerest thanks to our experts, Dr. Sadhana Gupta and Dr. Sharda Jain, for giving their wise inputs, because today the topic really needed some brainstorming inputs from our seniors. And of course, our panelists, they did a wonderful job today. Dr. Aradhana Singh, Dr. Vinita Avasthi, Dr. Divya Yadav, Dr. Upma Jaiswal, Dr. Pinky Saxena, Dr. Mamta Tyagi. My sincerest thanks to my co-convener, Dr. Ayushi Agarwal. She's always the person behind the screen. She was supposed to conduct the panel, but then she's out of station and she could not do it this time. And my thanks to the IT team. For without them, our webinars would not be possible. Thank you, Bhumika, for conducting the session and coordinating, making all the flyers so very nicely. So thank you once again, everyone, for joining the session, and my sincerest thanks to all the audience, because without them, there is no point in conducting these webinars and conducting these sessions. So thank you, everyone, so very much.
Thank you, Babita, for always trading through. Thank you, Babita. Thank you.
And sorry, ma'am, my sincerest thanks, I'm so sorry, to President UP chapter of NIGF, Dr. Manju Verma ma'am. Ma'am was so kind to join and she was present throughout and she was giving her inputs and she was so active throughout the session. I'm really sorry, ma'am, for missing. And
the same is for Dr. Anuradha Khanna.
Yes, yes. And Secretary NIGF, Dr. Hema Shobne, she was also really kind to join and she gave her wise inputs. Of course, Anuradha Khanna ma'am, I have mentioned she had been present throughout. And ma'am, please do share your critical care workshop details in the group. We will all join and I will spread it in our society. Thank you so much, ma'am.
थैंक यू मैम। यहाँ पे एक छोटी सी चीज मैं कहना चाहूंगी।
जी मैम।
जिस चीज ने आपको फायदा दिया है, आपकी प्रैक्टिस को बढ़ाया है, आपकी ऑनर को बढ़ाया है, आप 20 लोगों से शेयर करें।
जी मैम।
हिंदुस्तानी उसको शेयर नहीं करता।
नहीं अपनी ग्रुप में हम लोग GOGS में करेंगे मैम।
यूनिटी मींस, यूनिटी इज शेयरिंग नॉलेज। आपको जहां से आपको फायदा हुआ उसको बताए जरूर कि हमें यहाँ से फायदा है। यस। एंड आपने ये थैंक्स की जरूरत नहीं डॉक्टर साहब, आपको आपने मौका दिया ये देश, उसको उनको उसका सिर पे रखना चाहिए कि आपने उनको मौका दिया। उनकी मेहनत बताएगी कि उन्होंने कितना अच्छा किया। Am I clear?
Yes मैम।
ये बिजी शेड्यूल वाली बात गलत है।
अच्छा।
Nobody is busy। ये मौके बहुत कम मिलते हैं।
जी मैम।
ये मौके बहुत कम मिलते हैं। We have chosen डॉक्टर साधना, ये गॉड सेंड मैसेज है, ये गॉड सेंड अपॉइंटमेंट है इसका।
Yes.
People are not chosen just like that. The people are chosen with the hard work and the God message comes कि भाई इनको चुनना है। And that is what the difference we are going to make. यहाँ पर मनी पावर नहीं है NIGF में, यहाँ पर कोई किसी का गॉड फादर नहीं है। यहाँ पर आपको अपनी मेहनत से काम करके हमारे देश को आगे ले जाना है। एक स्पेशलिस्ट को बनाने में 4 करोड़ खर्च करती है सरकार हमारे ऊपर, और 4 करोड़ तो आप इस जन्म में कभी भी सिंपल ब्याज भी नहीं दे पाओगे। ये आपको करना है, ठीक है।